Yeah, I think it's still back here.
Yeah, you think so? Well, but you can't see the slides back here.
I know. If this mic is on, should we turn this mic off then? Do you have a lavalier? Morning. Good morning.
I'll have
When in doubt, always use sports analogies. It's the only way I understand things.
Yep. So, okay. I've got 10 o'clock, so we're going to get started. Welcome back. Everything okay? So, I've got a couple of announcements. We do have extra seating, so nobody should be sitting in the back. Hopefully you got a table in front of you. If you don't, I see lots of open chairs. So please keep that in mind. We do have, for the CE, there's a couple of CE things that have come up. I think the CE situation has been corrected, so you can always go in there that way with the evaluation. The other thing on the evaluation, they don't have to be done today, right? You've got I think you got like 30 days to get that evaluation in. So don't get frantic about the evaluation and getting your certificate and all that kind of stuff. So we'll definitely take care of that. So, but if you do have any questions over by the exhibitor, there's a slide set over beyond that door there. And if you have any problems, Miss Keisha James will take care of you there. Okay? All right. Any other questions you have? All right. We'll go ahead and get started here. See if I can get this to work. Here we go. Oh, it's a little slow. So we've got our next topic is going to be about sports-related concussion. And since you already know me, I wanted to introduce my co-presenter here. This is Dr. Lauren Poindexter. She is a specialist in concussion management. She's a former professor at the UMS Department of Orthopedics and Sports Medicine. She's worked a lot of concussion, and she's been at Arkansas Children's Northwest. She currently is an adjunct professor at NYU Rusk Rehabilitation Department. She's not only in her past, she's been an athletic trainer as well as an EMT, and add to that sports medicine, and add to that physical medicine and rehabilitation. So I don't know about y'all, but I think she's qualified, right? So, but anyway, that's what we're going to bring to you. The other thing I kind of wanted to show you is there's two of us up here, but you're going to see 4 names there. And what we mean by that is we have this whole thing, you're probably going to go, what is this all about? So a couple of things that we're going to try to do is we're going to talk about sports concussion, particularly in pediatrics, and talk to you about what we identify as problems and possible solutions about all that. So what happened and I'll tell you a little background on this. About 2 years ago, I presented at the EMS conference just about concussion, just kind of a standard, this is a concussion, this is what it's about, because we're in the brain injury program, right? So I had a guy that was doing my technical support. His name was Tim Jackson, the name at the bottom. Tim Jackson is a seasoned paramedic. He works at MIMS. And he said, I had a situation where I was doing medical coverage at a mixed martial arts event. And he said, one guy literally got the pus beaten out of him. I mean, he was out. And I'm not going to tell you who it was, but there was a medical health care provider that said, he's okay, send him back in. And he was just appalled. And he's really the reason. Tim Jackson is the reason we got together. We've also got Dr. R.J. Elbin. He's at U of A. He does lots of concussion research. We try to meet about once a month and talk about what we can do to help the situation with concussion in Arkansas. So we've got a little bit of an idea here that we wanted to share with you. So this is what we're going to talk a little bit about. We're going to talk about concussion morbidity, identifying the problem, defining concussion, assessment, existing systems of care. And I think for you as providers, for you as parents, I think these are things that can be very important and very helpful to you. There are a lot of things in the system of care. It's kind of, we'll talk about that a little bit later. What we're going to present to you is really, the core of it is what we present to EMS professionals, paramedics and EMTs, because we see a little angle that may help the system of care. So, the background, concussion. You probably know it's fairly prevalent out there. 58 to 88% of all TBIs are concussion, meaning mild TBI. That's over the majority of all TBIs, right? So we got 3.8 million sports-related injuries. I'm actually going to present to you some very specific things that Dr. Elbin found out. He's got actually 2 things we're going to share with you. He's worked with the Arkansas Activities Association on the sports medicine subcommittee, and some of y'all may be aware of that. You guys at Children's are probably very well aware of that. But he actually pulled together data on concussion, and he queried 176 high schools of the 293 that were affiliated with the AAA, and he got a 60% response rate. So that's not bad, right? And so the highest number of concussions were football, followed by women's basketball and men's basketball. 95% required, 95% of the high schools required that they have medical evaluation by a physician. This is kind of interesting to me. I know this is just a snapshot. This is just 1 year. But look at cheerleading and look at some of the other things. Women's soccer beats men's soccer, which is kind of amazing. I had soccer kids, and I was like, man, watching those boys run versus the girls, but the girls get clanked up pretty good too. So let's talk a little bit about the problem. You're probably going, what in the heck has this slide got anything to do with anything? So who knows about sports concussion in a high school? Could it be the school nurse? Well, where do concussions happen? We just said it was with football, right? What kind of medical coverage do you have in high school football? Well, if you're lucky, you got an athletic trainer, right? And most athletic trainers are pretty up on concussion management, recognition and management, right? But we were thinking, I've grown up in Arkansas all my life. If I'm in Cedarville High School, do I have an athletic trainer? If a kid gets a concussion at Cedarville High School when they're the home team, who's going to take care of that kid? Are the coaches going to recognize it and pull this kid out? So that's kind of what we're getting at. So there you go.
Thank you. Which one goes forward?
To the right.
Okay. So Danny and I have been lecturing together on this topic for some time. And as he mentioned, typically we give this lecture presentation to EMS providers. I know that today's audience is a little bit different. How many of you are nurses? How many of you are some sort of physical therapist or rehab specialist? Okay, so lots of physical therapists. And then do we have any PAs, NPs, physicians in the room? Okay, how about administrators? Who's also an administrator? Okay, so a handful of administrators. So we'll try to gear this towards physical therapists. And even though we're talking about EMS, why it matters that you hear this is because we are all part of the continuum of care, all right? How many of you, maybe as physical therapists, might be sitting in the stands watching your own child participate in a sporting event, and either your own child or someone else's child sustains a possible head injury? What are the chances that there's not an athletic trainer there, and you may be the only medical provider who has any insight into concussion or head injury? Okay? Physical therapists are so essential in managing and rehabilitating patients with concussion. I may be a physician, you may be like, oh man, she's been in school for 100 years, and yes, it feels like it, but I can't do 100% of the things needed to get a child or an adult back to their daily life after having sustained a mild traumatic brain injury. I can't be 100% of things. So I need you, and I trust you. You're the experts on rehabilitation. I trust you to help guide that child or guide that adult back to their daily activities after having a head injury. I also want you to know, what do we want EMS to know? What do we want athletic trainers to know? And maybe some of these acute management skills or acute management viewpoints are going to be new for you, and I love that we can share that. Also, I cannot sit still worth my life, and some of you probably can't either. Please do not feel like you have to be rooted to your chair during this presentation. If you need to get up and get coffee and water, please feel free. So what is a concussion? We alluded to a concussion being a mild traumatic brain injury, but by and large, concussions, especially sports-related ones, have negative imaging, and that confuses the vast majority of patients and families. So if anyone says to you, gosh, it's weird, why is my kid acting like this? It doesn't make sense. Their CT scan was normal. You say, absolutely, that's part of the definition of concussion, okay? Does a child or an adult's head have to hit the ground or hit a stationary object to get a concussion? No. It can just be that the momentum of the brain moving can transfer that energy to the inner side of the skull. So the head doesn't have to hit anything. The brain itself can just hit the inside of the skull, and that can be enough to cause dysfunction within the brain. Okay? So it's a functional injury, not necessarily a structural injury. Very important to educate your families, your patients, that is consistent with negative MRIs, negative CT scans, okay? Just because someone has ongoing symptoms, I'm not gonna have them get an MRI if this is consistent with concussion, okay? So as I mentioned, it could be a whiplash maneuver. I was most recently the head team physician for Razorback women's soccer. It's not uncommon that I have to completely and totally discontinue someone's collegiate sports career because of an accumulation of concussions, an accumulation of these functional injuries, which really hinders their ability to be completely normal humans, all right? So it can be football, it can be soccer, and I was formerly a cheerleader, got dropped a lot, and I do see a lot of cheerleaders also with head injuries.
So we're going to do a kind of a brief overview of the pathophysiology of concussion, because I never really knew this stuff. And so, just reviewing some of you guys that are healthcare providers, You got the dendrites, you got the axon, you got the cell body, you got all that going on. You got the wave of depolarization going from left to right in this shot. And then, of course, you've got the synapse where you have the release of the neurotransmitter. So the signal arrives from the dendrites to the cell body. Then it travels on down the axon to another cell. And then it goes to the neurotransmitters. And the neurotransmitters jump that little leap across the channel and goes over to the next body and dendrite, if you will. So if you'll think about this, this is really the substance of a concussion is about the neural intact nature of the membrane, of the neuron membrane. So what we see is the two particular substances we have involved is potassium and calcium. Oh, too close. Potassium and calcium. So when you have that shock, you have that initial hit of the head, that down at the microscopic level, at the cellular level, that membrane is disrupted. And when it's disruptive, it cannot keep the potassium in, and it can't keep the calcium out. So the potassium's rushing out, the calcium's rushing in, and so when that happens, the cell's acting like, well, this is the normal transmission, right? So it's starting to shoot and fire, and you're going to get at the end. So you can see the calcium running in. Go to the next one. And so then at the end plate, where there at the neurotransmitter, you got the neurotransmitter constantly firing, okay? And so we sense that. I mean, I'm no neurologist. I'm sure a neurologist could explain how that happens, but you're just absolutely exhausted, right? And so that's your body telling you it's time to, slow down. And so you've got this period that's really dangerous. And I'm going to say this again, it's really dangerous, whether it's for chronic outcomes or whether it can, in certain situations, it can even be fatal if it's over enough area and the recovery period is not allowed. So those are some real problems. So again, now, following the concussion, the body still tries to heal itself, right? And let me back up here again. If you've got this chaos going on and you send a kid back into sports, they're going to make this even worse, right? And you're going to just totally blow up this membrane. And you're going to cause actually neuron death, right? So that's not a good thing, right? So with time, the membrane starts to heal itself, and then, the potassium is withheld in, and the calcium is kept out until the next firing eventually. But still, in this case, we still got damage, and we still have that spontaneous firing that's going on that shouldn't be happening, right? And so now, after many, many days, usually about 2 weeks, we start to see that things start to get back together. Then you got your normal neuron, everything's firing back to normal. All right, so this is this critical period that I'm telling you about. So we have it's a mismatch with energy. Your cell can only keep up so much, and you've got a major mismatch that happens here. And so you can see you've got your normal activity, and then you have a massive request on the cell to have more glucose. And there's a deficit there. And so, as you know, when a cell's not able to function, it's going to start to do some decline. And so that can be a real problem. So, we've recognized this for some time. And Karen McAvoy has done a lot of work, neuropsychologist, and she's started up kind of the REAP concussion protocol. And it basically says remove, reduce, educate, make sure that the kids know things like blue screens. They don't need that in that first 24 hours or so. They need to just slowly, and educate has to do with the parents too. If the parents don't support this, that kid's going to pretty much do whatever the parents say, right? And so you adjust, you accommodate. Because of that, you know that people have different levels that they adjust to. Some people My kid had a concussion when he was a senior in high school. We had our athletic trainer. He was out for 2.5 weeks, but he was like that. He snapped right back to it. No more headache, no more fuzziness, and he was fine. And then PACE is going to be up to the individuals on the PACE. There's a website there. We've got Arkansas REAP, that we've got a very specific Arkansas manual that we've got out there. You can link into that. You can link that into our website. Here you go.
So we'll move on to acute recognition and management of a concussion on the sidelines. And once again, it says EMT here, but there may be opportunities where you are the first person on the scene, okay? Or your friend calls and says, hey, yeah, like, I don't know, like, Gavin just is not acting right, and he had this weird tackle yesterday. And you may be the first person to step in and say, I've got some questions for you. So some of the things that we use to evaluate acute concussions are a number of tools, and one of which is called the Sport Concussion Assessment Tool, or the SCAT-5. Of note, there is now a SCAT-6, okay? But SCAT-5 has been validated and used most frequently, is very widespread, and was actually designed to be utilized on the sidelines of a sporting event. There's a number of elements of the SCAT-5 that we look at as physicians, an athletic trainer or an EMT may only address a couple of these elements. So we'll go through those. So the red flag signs, these are critical elements that help an EMT or paramedic determine, or an athletic trainer to determine, does this person need to go to the hospital now? Okay, so if there's a suspected head injury and any of these things are present, the athlete, the student, should likely be transported to the emergency room. All right, so neck pain or tenderness, seizure or convulsion, double vision, loss of consciousness, weakness or tingling, burning in the extremities, altered mental status. Okay, over time, concussions can evolve. Vomiting, severe or worsening headache, increasingly restless or agitated, GCS less than 15, visible deformity of the skull. Of note, if a student athlete is merely confused and some of their answers aren't appropriate, that's a GCS 14. That's not a 15. So when in doubt, you're not wrong by recommending that somebody seek emergent care, all right? And we are not trying to change acute management, all right? So some on-field signs and symptoms. If anybody was ever watching or saw the video of Tua Tagovailoa with the Miami Dolphins have some on-field posturing after his head injury, that's big, bad, and scary. Okay. As a former athletic trainer and as a physician, I'm not waiting for the ref to call me on. I'm like, I'm out there, and ESPN's like, what's that girl doing? But evidence of mechanism by itself can be a critical factor. So y'all, I'm sure, were watching Razorback football last weekend. There are some really ugly tackles that when some of these young men get up, I'm shocked that they're even getting up off the ground, okay? As an athletic trainer or a team physician, if you're on the sideline as well, just follow the kid around. See if they're looking in the right direction. See if they're acting normally. See if they're maintaining their balance, okay? I watch those people like a hawk. Do you think all student athletes are gonna come up and be like, gosh, I don't feel good after that big hit? Absolutely not. They just wanna get back on the field. That's why we're educated adults, and sometimes we have to do the hard thing and step in. Symptoms may be present, they may resolve, they may come back again, they can wax and wane. That's not uncommon. And then there's always the coach and the parent issues. Do you think I've had to pull a collegiate athlete from a game and made a lot of people unhappy with me? Absolutely. It's really fun during an NC2A tournament when you pull a starting player. But that is absolutely the best thing for the long-term health of that individual. And as we're going to see, you're backed by Arkansas law when you do that. Observable signs. Obviously, things that are really concerning. The kid's lying motionless on the surface. I hate when that happens. Usually the paramedics are also on their way as I take the field, okay? Falling unprotected to the surface. Watch if the child or the adult puts a hand out or if they're just falling flat, okay? Balance or gait difficulties, stumbling, wandering into the opposing team's huddle. We see that. Confusion, okay? Blank or vacant look. One of the tricks athletic trainers can do is to pull the kid's helmet and not give it back. What do you think the kids do?
Get another helmet.
They go take someone else's helmet and they go right back in, okay? We also have given referees the power to say, you get off the field now, okay? Thankfully, referees can step in and do that. Facial injury is always concerning. Seizure, definitely concerning. Those kids are going to get packed and sent to the emergency room. And again, high-risk mechanism of injury. They may be getting up after on their own power, but I don't want them going in on the next play. Again, most student athletes are going to downplay their symptoms. They may not even have symptoms right away. Okay? Parents may not be knowledgeable in signs and symptoms. How many times have you been helping a patient rehabilitate from a problem maybe stemming from a motor vehicle accident and you're like, I think you've got more problems than just this knee. I think there may have been a head injury at the same time. We see that a lot. And our recognition of signs and symptoms, it needs to be careful and it needs to be individualized. Not all concussions look the same. They don't all act the same. Some people can have purely balance difficulties. Some people may have emotional changes, right? An otherwise easygoing kid could start to become aggressive, right? And so assessing symptoms is more than a yes or a no. We want to be very careful and intentional when we assess a patient after an apparent head injury, okay? And what do the symptoms tell us about the injury, all right? Is this likely to be symptoms that we expect to improve with time, or are these symptoms that could be easily worsened by the kid going home and then playing video games all night long? All right, so very careful. This is where education of all of us, but also education of our parents and our families means just so much to the patient's recovery, okay? Besides concussion, what might else this be? It's really hot, y'all. Not necessarily today. It's football season. It's really hot. We've already had at least 7 or 8 deaths nationwide with this football season alone. Okay? Head injuries, heat stress can look and act very, very similar. Same with dehydration. Same with migraines. Okay? Do you think all of the student athletes in the state of Arkansas are well fed and well hydrated when they go in to play their football game on Friday night? Not even close. Okay? So some of these kids could be exhibiting signs and symptoms of a concussion, but it's actually hunger. Not uncommon. Hyponatremia, low sodium, or just electrolyte abnormalities in general, okay? Also, some kids have inflammation of their Wuss gland and we need to call the wambulance, okay? That's after everything else has been ruled out, so it could be attention-seeking behavior. Some teenagers are just weird. Some adults are just weird. Okay? That's why it helps to ask the coaches, helps to ask the parent, is this typical behavior you see of your kid? And they're like, yeah, they're like a monkey. I've had parents be like, no, my kid is like literally the nicest person ever. And they're like bouncing cuss words off the walls. And you're like, that's weird. Okay? What do we tell parents and coaches? You are backed by Arkansas law if you step in as a healthcare provider and say, I think this kid might have a concussion. They're not going back today. Arkansas law supports you, okay? It is Arkansas law that if there is suspicion of a head injury, they can't go back to play that day. Not a confirmed, I don't care if it's a confirmed concussion. If there's suspicion of a head injury, they can't go back to play that day. And the child or adult must be cleared prior to return. All right? So quick concussion facts. And Danny reserves the right to steal this from me, like at any time. So if he comes up and just rips this out of my hand, that's totally okay. So often patients will have a delayed presentation because they don't think the mechanism's that big. I played sports my whole life. I got beat in the head with all sorts of elbows, balls, you name it. And my concussion came with a minimal glancing blow from a football to the temporal side of my skull. I shook it off and kept playing. I mean, it was flag football. I was like, that was nothing. But the next morning, I fell out of bed and stumbled to the bathroom and thought, this is really not normal. So my presentation wasn't till the next day. Typically, concussions recover with rest within 2 weeks. That's great. But there are some known risk factors for long recovery. Dr. Bircher, is going to talk a little bit later about continuing to play can actually worsen recovery and double the length of time to recovery. So risk factors, returning to play that same day can make things much, much, much worse, okay? Having prior head injuries, we see this a lot in soccer. History of anxiety, depression, ADHD, learning disabilities, they can make recovery from concussion very, very difficult. And anyone who has an existing headache or migraine condition can also have a more troublesome recovery. So as I mentioned, the Arkansas state law says any child, any adult practicing an organized sport should be removed from play that day and cannot return until they are cleared by a highly trained healthcare provider. Okay? And I believe our physical therapists can do that now. Can you guys do that now? Does our state law allow them to do that now?
I don't know about physical. I don't know.
It's sort of been a debate lately, but I just feel so blessed in Northwest Arkansas. We have incredible physical therapists that are highly trained in neuro rehab and do such a beautiful job working together as a team to help get these kiddos cleared. Okay? So coaches must receive training. Athletes and parents sign the concussion fact sheet, but do we think they totally read all the words? Probably not, and they probably don't remember everything. That's our job. And again, an athlete suspected of having a concussion should be evaluated by a trained healthcare professional. I do not mind if my athletes see a physical therapist before they see me. I'm okay with that. I just don't want them playing, and I want them to be taken care of somebody who has the skills and the insight to educate them and help to rehabilitate them appropriately. And then the stepwise protocol we'll review a little bit later today, but in essence, the fastest return to play after concussion is at least 5 to 6 days, okay? That's a good thing. That's a protective strategy.
Okay. All right, so Dr. Elbin wasn't able to make it today, but he allowed us to share his research that I think's applicable. And honestly, we may be preaching to the choir, but sometimes there's things that are written as law, Arkansas code, and people may or may not follow that thing. And the other thing that I'll say about it, I feel strongly about this. We're a proud country, right? We are tough. We deal with things. We heard Carol talk about resilience, but it's kind of like you have an athlete out there and you got the parents, they're type A, and they're like, you're going to go, you're not going to stop, right? And, but what I want to, the reason we're bringing this up, and probably I don't think an IRB would allow this study to happen right now. Just follow me with this. But we've got to get the word out socially among the people that we know. If a kid is not silly, if he sees stars, he or she sees stars, they have any kind of an incident that causes pause, they have ongoing headache, they need to be pulled out, right? They need to be pulled out. So, if you ever get somebody, and, I'm just going to say, I listen. People go, well, he's not, he just needs to be tough, This is not the time to be tough, right? I want to be tough in other things, but not at this point. All right, so this is Dr. Elbin's research. He pulled this idea together, on-field management, this scenario of no same-day return and return to play is really what he's emphasizing. So he basically had a study design where he recruited in about 60, almost 70 players that they were monitoring, and they basically did mixed methods, and they monitored out the baseline. They did monitoring. They used the impact study. They did baseline, and then at 1 to 7 days, and then at 8 to 30 days, they did evaluations. And they split the groups. They had removed from play, 34 continued to play. And again, I think any IRB in this country now would not let them do that. So here's where the results. The blue line are those that were removed from play. The red line is those that continued to play. Look at their verbal memory. Right off the bat, verbal memory wins, and they're very good. Visual memory, again, very similar lines, way above. And the scary part to me is even at 8 to 30 days, look at the gap. It's just scary. And then processing speed, again, way above, and look how their processing speed gets better. And the reaction time, look at the reaction time has gotten better with the removed group and took a while for the continued to play. So symptom scores, again, you can see those that were removed, sure, they had problems for a few days, but they came back pretty well. So this is just, it almost breaks my heart to look at stuff like this. You have, 22 days plus or minus 18, double the recovery time. So they've got very quick recovery times if they're removed. But look at that, 44 plus or minus 36, you're looking at 80 days out there that they're still having symptoms. Do you think that's a problem? It's a huge problem. So those that continued to play were 8.8 times more likely to have prolonged recovery. And then you can look at just on a dose response level, those that were immediately removed, you can see they performed much better than those that were, even just a little bit. They were continued for a little while. Again, there's still big benefits from removing those kids immediately. So the research finding continued to play was associated with worse. You saw that. Athletes who stay in the game will take longer to recover. Continuing for just a few minutes can have adverse effects. So.
Once again, going back to the red flag signs, we can't emphasize this enough, okay? This is never going to change. Big, bad, scary signs that indicate something big, bad, and scary inside the skull, or inside the neck, this needs to go to the emergency room, okay? So that's not going to change. So what happens after the athlete has been removed from the game, right? One of the things we're sharing and why we're talking about this to so many different groups, and Dr. Bircher mentioned this, social awareness is so key. Because there are so many communities in the state of Arkansas that don't have athletic trainers on the sidelines and don't have athletic trainers in the schools. So share this information with your friends. If EMS or a physical therapist or a nurse is at that football game and no athletic trainer is present, we want that individual to feel empowered and enlightened and be able to intervene in a really positive way. And so what you can do, or what EMS can do, is to do a very, very brief assessment and to also educate the student and educate the family and have a meaningful conversation with them about what to do next, where to go next. So this is going to be too small for you to see, but I want you to know that the CDC, the Centers for Disease Control, has a wonderful website called Heads Up. And a lot of this information is on the CDC Heads Up website. And I love that. Some of you are already writing that down. And so you don't have to be the font of all knowledge. You don't have to have this memorized. You just have to be able to give the family some next steps. Hey, I'll tell the family this. I want you to pull out your phone, open up your browser, and I want you to go to CDC Heads Up. So if I'm covering a mountain bike race out in the community, and I've got a kiddo with a suspected concussion, their parent can pull this info up as we're standing there. And I'll say, hey, look at this. These are some warning signs I want you to be aware of. And if any of this stuff pops up tonight, I want you to go to urgent care. All right? So again, you don't have to have all the answers. You just have to recommend where to go next. And so the most important thing that we can do for our kids or our patients immediately after that head injury, we've pulled them out of their sport. As Dr. Bircher mentioned, no phones, no computers, no TV, no movies, no video games, rest. Reduce the stimuli on that brain because the brain needs to cope. It needs to initiate the healing process, and rest is one of the best things we can give that brain. Now, this is not like the dark ages when we were kids and we were told to stay in a dark room, don't come out, but also don't fall asleep. What? Terrible recommendations. What were we doing? We don't know. So we want kids and adults to rest after a head injury. We want them to stay hydrated. We want them to eat good food. We want to give the brain everything it needs to try to heal. Assessment and testing is important with a trained healthcare provider. And cognitive rest may include not going to school for a couple days. When my patients are symptomatic after a head injury, I don't even let them take standardized tests. How many administrators have I made really mad? They get so mad. And these little kids are like, well, I'm just not going to go to school because my brain is broken. They're awfully adorable. Sounds a lot like me as a kid. Anyway, so cognitive rest may include holding kids out for a couple days from school, okay? And if there are tests coming up, I recommend that you say hey, just reach out to your teachers. Mom, Dad, reach out to the teachers. Say, hey, listen, Gavin's not doing really great right now, getting a lot of headaches, having trouble reading. Do you think we can reschedule that test? So-and-so is, Gavin's gonna go see a doctor on Friday, but in the meantime, let's just hold him out from school and see what the doctor has to say. You're not wrong for doing that. And the last one down here is accommodation examples. So maybe the kiddo has a lot of energy in the morning, but then by lunch, they are done. They've got a raging headache, they feel nauseated, they're getting really anxious around their classmates. Just bring them home, okay? So accommodation in the classroom or accommodation at work can look like a lot of different things. And the really awesome stuff is you don't have to come up with a whole plan by yourself. The Arkansas Activities Association and the CDC already has a bunch of resources for teachers to help them implement accommodations in the classroom. One of my favorites is saying, hey, rather than calling mom or dad and sending you home right away, why don't you go to the nurse's office and take a 20-minute nap, have a snack, have some water, take a 20-minute nap. If you wake up and you still feel like junk, then go home. But let's just see what a break feels like. How many of us could use a nap at work? Yes, everybody. We don't even have brain injuries. So the return to activity timeline is somewhat structured, but remember it's a continuum. So we're not necessarily hopping from one stone to the next. We're gradually progressing through these stages. There are stages of return to school and homework and the workplace, and there's stages to return to sports activity and exercise. Guess what? If you've got a kiddo that can't stay at school the whole day and pay attention to class and pay attention to school, they don't get to do sports. Society sometimes has it a little backwards. right? So kids need to be able to learn and pay attention and be a normal kiddo at school before they can run around and go berserk on the football field or on the soccer field, okay? So returning to activity can be very gradual. Sometimes our kiddos can't tolerate the classroom, but they can sit in a quiet office at school, maybe with, or even just sit in the school nurse's office. If there's a little desk in there, they can work quietly with the lights dimmed. That might be a really easy way to accommodate for their photophobia, right? So we progress with regards to exercise. We go from rest to just walking around the block. I always ask kids, hey, do you have a dog at home? Can you take responsibility for walking your dog? I want you to wear a baseball hat and I want you to wear sunglasses and walk the dog around the block with your parent. See how you feel after a little bit of exercise. If they don't feel good walking around the block, I'm not going to let them run. So it's a progression. It's a stepwise return to activity. We have them do light aerobic exercise before we have them do sports-specific exercise. Okay? Sometimes those kiddos can do exercise inside in a gym, but they can't tolerate the heat outside. So their body is going to dictate what they're capable of doing, and that's where our physical therapists come in. Because it's y'all that do such a competent job at progressing those patients as their body allows them. Dr. Bircher showed us a slide about reaction time following head injury. It's that slowed reaction time that can be the most problematic and last the longest after head injury. And who's going to be the best person to recognize their slowed reaction time? You guys, for certain, okay? And so when you have a kid or you have an adult who's recovering from head injury and you're like, oh yeah, they're totally asymptomatic, does that mean they're ready to go back on the soccer field or they're ready to go back on the football field? Not necessarily. The reaction time is critical because if you have a wide receiver, for example, you have a wide receiver, they're running a route, their reaction time is slowed. I don't care if they drop the ball. I care if they can get out of the way of the oncoming tackler. Okay? So prolonged reaction time, abnormal reaction time after head injury can predispose that athlete to further injury because they can't protect themselves. So I have parents who are like, I don't understand, like Brian feels fine, he wants to go out and play, and like they think that like just because Brian was this amazing athlete before the head injury, he's not automatically an amazing athlete now, and I'm like, whoa, bro, you may be setting yourself up for a low light reel, not a highlight reel. Okay, so if your reaction time is slow on the line, what's wrong with your quarterback? Now they have a head injury, right? So the reaction time really matters. So present system of care, excuse me.
I got it. Okay.
I told you he's going to steal it.
Yeah, I got to tell her what to do, you know. Now, the present system of care is athletic intervention. We know that the coaches and the athletic trainers, if you have them, are where it needs to happen. Because initially the parents are going to be very hesitant for the most part. And then the parent involvement is really key. The clinics, you have UMS Northwest. We got Children's has a concussion clinic. I understand they got two types of concussion clinics for sports medicine, and then they got a regular concussion clinic, and then local family practice. We need to get the schools involved. We got Bethany Compton is working with Easter Seals to get the word out on Return to Learn with the teachers. We started, just from our program's perspective, we reached out to Little Rock School District and we said, well, I don't know, they're busy, you know. You got a teacher that's dealing with 30 kids with 8 hours over an 8-hour day. How in the world, you know, with all the buzz and background noise they've got, you know what? they stepped up and they were like, we want to know. We had a few individuals that they wanted to work with the existing system. You can't just say, oh, we're going to save you and we're going to have this concussion program. That is not going to sell. It's got to be something easy for the schools to adopt as they get on board. So, yeah, and then maybe our brain injury program call center can help. It hadn't happened yet, but we foresee a situation where maybe we can help. So you're going to go, what is this about? This is what I think Dr. Poindexter and I are worried about. The red are all the high schools that don't have athletic trainers. That's a lot, guys. That's a lot of football going on. That's a lot of soccer going on without athletic trainers. And that's why we believe that, now EMS, don't get me wrong, EMS is not at every sporting event, but they are at a lot of them. And so to us, we think EMS could serve a good role in trying to bridge that gap where it needs to happen. But you can't just talk to EMS. You know, we're going to go out to Pope County, talk to them about concussion. I don't want to talk to just EMS. I want to talk to the local schools at the same time so they can all work together to get that system of care. You can be the brainiac and know everything about concussion, but unless you've got a system of care to reach out to these kids that, you know, they don't, that's not on the script. They don't have a plan to have a concussion. You know, you've got to have people that know to recognize it and get them in that system of care. And then this is something that I think is really cool. You know, I was kind of a newbie to the sports medicine subcommittee for the AAA. I just sat in there. I was in there for like a couple of meetings. And then we realized they've got, I didn't even know about this, but every AAA meeting, and now I understand the NCAA and the SEC, they basically have a safety pregame timeout where the referees have to talk to the coaches. They're going to go, you know, in case, what was the professional athlete that went into cardiac arrest? Anyway, you know, they had, you know, EMS is here, the physicians are here, this is what we're going to do if something goes down. They talk about that. Well, guess what? When they had this card, EMS wasn't even on the card. And so I was like, well, boy, I'm going to have to write like a 40-page paper and have to prove our point. And I called them and I said, hey, we need to put EMS on that card. What do we need to do? He goes, oh, we'll put it on. And it happened like that. So they were just that open to it. And sure enough, we've got that card out there. So it's up to the coaches, the referees. It's really a team effect where you got to get them involved. But we still got to get the schools involved too, EMS and the schools. All right, so you're back. We're a little behind. Yeah.
All right, so I'll try to progress through this. So the neurologic screen that we like to perform on the sidelines has been updated just a little bit for the SCAT-6. But I want the patient to try to read aloud a simple paragraph, okay? I want to determine, do they have pain-free, passive, cervical spine motion? And I mean everything, flexion, extension, lateral flexion, rotation. Okay. We can also, I will palpate the neck to see how they feel. Can the patient move their eyes in all cardinal directions without double vision? Okay. How about their near and far distance is also something I ask them. Does the scoreboard look more fuzzy than it normally does to you? Okay. The finger, nose, finger coordination test. Okay. That's helpful with also assessing reaction times. And then tandem gait, that's the, I had a 12-year-old go, oh yeah, that's the field sobriety test, like the one the cops do. And like the mom and I were like, you're 12? And the kid's like, oh yeah, I watch all those cop shows. And I was like, that was the right answer, sir. Holy moly. So a basic neurologic screen can also bring up some concerns, okay? A balance examination, we're not gonna go into this, but this is something that athletic trainers can do, or I can do in my office, and you can do as physical therapists, just checking their balance, all right? And the EMS concussion protocol that we're looking to augment. Okay, again, not changing the management of emergent care. So again, the red flag signs, they go to the hospital, but we want to talk more about education with them. Do you do the considerations?
Yeah, I mean, I can. Yeah, so there are some considerations for EMS medical professionals. As the system exists right now, electronic medical records, all that kind of stuff, you got HIPAA concerns. There are all these kinds of things that can kind of get in the way, and systems have to work through all that. And, you know, I'm not going to tell you, I mean, it is a problem. It's something we've all got to work at. But I think at the local community level, those things can all kind of work through. And then you can just a little bit.
We just went through the neurologic assessment, which is fine. And once again, if there's only one thing you remember today, it's that you are backed by Arkansas law to pull a kid from play.
Absolutely.
It's literally the law.
Cool. And this is just what AAA adopted. They let us put together the return to play protocol. Actually, they already had that. They allowed us to add the return to learn protocol, which is different from return to play, right? And so these are some resources. I believe we can allow the slides to get to you eventually, and so those are some resources there. The other thing we wanted to plug is we do have the Brain and Spine Call Center. If you ever have this, we can hook you into resources for concussion if you're kind of in a desert where you don't know where you can get any help. We're definitely there for that. We also did, don't do this. We did an online, don't go there. We did this for the last EMS group that we had at the state conference, and we asked them some questions. We asked, what's the provider type? You can see the mix. Then we asked them what trauma region they're from. So we actually had nobody from Northwest, which I thought was interesting. This was in Hot Springs when we had it. We asked them if they had a concussion history. So we had about, what is that? I can't read it.
Almost half.
Almost half. I was really surprised. I thought it'd be more than that. Normally we get higher percentage. AAA rule awareness, this was at the end, so they really should have been 100%.
Yeah, someone slept through it, obviously.
Failed our job, I guess. But and then we had concussion education. This is the one, to me, is where the rubber meets the road. They totally agreed. They felt like EMS, because I used to be served as a paramedic, and I'd go to a football game, and I was more concerned about, how good the hot dogs and the hamburgers were, So I was like, that's kind of the EMS mindset. And I'm like, you're really there for a job, And so there are, there's just not a good, social setup for EMS to really get in that mindset. But we're starting to reach out to them and go, no, this is really a thing. And you're not just there for those critical incidents. You're there for concussion too. Because they're all over bad head injuries. They're all about that. But concussions are like, try something else, that kind of thing. So, all right, service involvement. Again, most of them agreed that service should be involved in this kind of activity. So that's it. Sorry we ran over a little bit. We wanted to give you time to have any questions about what we had. Any questions?
We made everything perfectly clear.
Oh, we got one there.
Oh, just kidding. Yes, go ahead.
You were saying something about the Arkansas law protecting us, but when you posted that earlier, it says if you're a staff member. Does that cover us?
Well, I think the other thing that happens is you got to remember something we didn't talk about. Coaches and referees have to do annual training. Has to be IE, has to be CPR, has to be heat-related injury awareness, and they've also know about concussion. And so they're kind of on the hook. If you point out some stuff, and in today's day and age with video everywhere, if you see a kid stumbling around or something like that, I mean, all you got to do is call. I mean, I can see I know what you're saying. If I'm in the stands, what kind of power do I have? I'm going to tell you, you got power.
Yeah.
I mean,
you can also let the ref know.
They may call the police on you, but at the end of the day...
I'll bail you out. My husband's a lawyer.
Yeah. But at the end of the day, you're protecting that kid, and after things get all figured out, you're going to be fine.
You can also tell the referees if there's
Yeah.
a referee you can find, or a school administrator.
Because it's just not
Yep.
going to, and I get it, there are some coaches, and that's why this can be a problem, coaches and parents that look the other way. So, yes? Oh, sorry, we're rushing our mic people.
Thank you.
Run faster.
So I'm here today kind of attending on a double whammy. I'm a parent of a cheerleader who has recently been diagnosed with TBI. Cheerleading is actually not recognized by NCAA and not protected, nor is it in high school. What can we do? I guess in this room of all of you, I want to be an advocate to change this. What can be done? How do we educate? How do we get it in schools? Because I'm now dealing with 12 years ago a concussion, 0 clearance was required, multiple continued injuries, and now it's impacting her ability to be a successful adult. What can we do to change this?
Unfortunately, I'm not surprised by that story. Systems change is like hooking a tugboat up to an iceberg. Making noise, right? You're probably doing a lot of those things anyway. Having as many of us as possible, consistently reaching out. I was actually working on a project where we were trying to create a cheerleader or cheerleading specific return to participation in competition, and I have disqualified cheerleaders from ever participating again because of those problems. It's not going to happen overnight, and I want it to so badly. So.
Yeah, I'll expose my ignorance. I don't know if the sports medicine subcommittee has any purview over that, but I can ask. I can ask my friends there. You're giving me something to do. So yeah, that's
I
fine.
think it's. I remember there's a couple different national cheerleading organizations. I can also see what they have in place, if anything. Yeah.
That's where our problem fell, is she was diagnosed ADHD.
Yeah.
Easily.
Got an IEP 504 plan.
Yep.
Which ultimately served zero purpose.
Yeah. Yeah.
Yeah, and the general rule,
surprising.
if it's an IEP, what we've normally said, if it's an IEP, it's been it's just taken too long, to get action to that kid, because this thing should be
Yeah.
early on, and concussion is as a clock, so clock is ticking.
How are we on time? I don't want to
Yeah, I
run
don't wanna
over.
miss. I've got one more.
Are we okay?
Ray, go ahead. Here we go.
I got a question on soccer. When I was, my younger days, when I lived in New York, I played youth soccer, junior high school, and my sons played soccer. I coached the soccer. My grandsons play soccer. I don't ever recall ever having any kind of contact issue, head injury.
You're very lucky.
I'm serious, but are you saying that is something that is occurring?
Yeah, it's for sure. And I think back then, like even when I was a kid, I don't think we knew or were aware of what the signs of a concussion even were. Like I think about like the massive kicks I took to the head by soccer balls, and I was like, oh, I'm fine. The best thing to do is score a goal on the other team. But now that we're more aware, it may seem like, oh, there's more concussions in soccer. It may not be that there's more concussions in soccer. It may be that we're just more cognizant of the head injuries. The things I've seen just with the women's Razorback soccer team, again, taking just like nasty kicks to the face.
I got you.
The ball itself. And again, it doesn't have to be, it doesn't have to be like, oh, wow, that was a horrible kick. It was so strong. It can be the way the ball hits the head. Or with the headers, it can be the head-to-head collision. It can be a goalie hitting the ground at an odd angle when they've reached out to go for a ball.
Well,
Yeah.
Here's the deal. Do we stop kids playing soccer?
No, no. You couldn't stop me playing soccer. I woke up on the sidelines unconscious, not having any idea where I was, stood up and was like, I think I can walk. Can I go back in? And my coach is like, yeah, have fun.
I understand. Now, what you're saying is be aware
We just have to wear and
when something
take care
happens
properly. Yeah.
to deal with it.
It's not like we would ask someone with a broken leg to keep running.
Right.
Yep.
Okay, that helps.
All right.
Dr. Poindexter, I have a question up front.
Oh, hi.
I'm Eddie Williams. Hi. You touched on it briefly when you and Dr. Bircher were talking about rest and no computers and all that, but is it safe to go to sleep after
Yes.
a head injury? We hear that all the time.
It's safe to go to sleep, yeah. Yeah, and in fact, and I tell my kids this, I say, you get so tired, don't you? And they're like, yeah. I'm like, do you know when your brain heals? When you're asleep? Like, kids actually intrinsically have really good instincts. Adults have very bad instincts. Adults, we are so practiced at overriding all of our internal cues. How many of you are hungry, and how many of you also have to pee? We override our internal cues all the time. So yes, taking naps and resting is important. The concern is you don't want your kiddo to sleep all day long and then they're like awake at night like a gerbil. You just want to implement a really healthy sleep-wake cycle. Good question.
All right. Yeah, I think we better.
All done?
I have
Okay.
Almost?
a quick one. So we talked about what happens after concussion. What are we doing before? Like, I know my kiddo is a big football player, and they just got these soft helmets that they wear in practice,
The
but
Guardian
not during the
caps?
game.
Yeah.
Over their other helmets. So what are we doing to kind of prevent some of this? Because my kid's not going to stop playing football.
No.
This is his path to college.
Sure.
And he's not going to stop.
I get that. Let me tell you this. So sadly, or I don't know what word you want to ascribe to this, even the average football player in high school sustains 300 hits to the head during one season. 300 hits to the head. Okay, that's not talking like, oh, I'm symptomatic from a concussion. That's helmet hitting helmet. So what do? Like you said, the Guardian cap, okay, not doing 100% of practices in full out pads, tackling form. I'm a huge fan of tackling form. I look like a little girl and I'm like all about tackling form. Also, balance, technique, skill, being able to evade and get out of the way of a tackler. Neck strength is huge. So I work, when I was with the Razorbacks, I worked with our strength and conditioning staff members with Razorback soccer, and they incorporated a lot of neck strength. Neck strength is incredibly important, okay? But skill, evasion, correct tackling, I'm very thankful. I don't care who hates it. I'm very thankful that we now have targeting penalties. Okay, I know y'all like those kickoffs look so weird right now, but that's also to reduce injury. Okay, and I think that's great that the CDC website is heads up. It's how you want to tackle. Did that answer your question, kind of? Okay.
All right, I think we probably need to get wound down. Thank you guys for everything, for your
Appreciate
attention.
y'all.
We're going to have a little bit of a transition here. Okay. Can we get the table? We've got a table. Were we going to get a table or no? Okay, yeah. Hang on. Hang on, guys. We're going to do a transition real quick. I think we're set. So, sorry about that, but we had to do a few little things. Our next speaker is Miss Jennifer Goodwin. Miss Goodwin is tetraplegic. She's an attorney, and most importantly, she is a mom. And she's sustained a spinal cord injury for 16 years ago. And after that, she was a pharmaceutical rep. And talk about resilience. She went back to the Bowen Law School and graduated in 2017. So she's an attorney for disability rights and focused on special education and employment issues. So we were really pleased when I already knew her before. I was like, man, anyway, we're just really glad she's here. So welcome, Miss Jennifer Goodwin.
The clicker.
There you go. Now you're stood up.
Perfect. Uh-oh.
It's a little slow at first.
Okay. Oh. Hello, how are you guys? I feel like I'm looking over a podium here, too. Do we want to pull it down? Thank you. Making you do double duty this morning. Perfect. Sounds good. All right. How are you guys? Good. It's good to see a bunch of PTs here, so that's kind of fun. If you've worked with me, I'm sorry for anything I may have said to you. At any point along the way, I see Twala. I know that she knows what my mouth does sometimes, so sorry about that. I'll just go ahead and apologize up front. So anyway, but it is so good to be here. Now, he kind of gave away my punchline in the end, but in being an attorney. And so I'm working for Disability Rights Arkansas, and I'm really excited to be able to give back to other patients that have experienced trauma and different things along the way. So I work with all different kinds of different disabilities. Mainly, I'm working in education and employment, and so working with kiddos who are needing IEPs and maybe not getting the services that they need at their school and helping to take care of that. And then also with people who have sustained injuries or were born with disabilities, whatever, and trying to get back to work. And so navigating through that process. And so I've been through that personally, and so I'm able to give a little bit of the personal spin to that for people that are ready to get back. So our mission and vision at Disability Rights is just to vigorously advocate for and enforce the legal rights of people with disabilities. And then also we just envision in Arkansas where people with disabilities are equal members of their communities and can dictate the course of their own lives through self-determination. So we're really big in just allowing people to be able to, chart their own course and make their own paths and plans. And, lots of people told me no along the way, and I told them to hide and watch. So that's pretty much what I'm telling my clients to do on a regular basis, and just hoping that they can see that and get through it as well. So I feel like you guys have already got the introduction of me, so here's me. All right, so today we're going to go through just understanding the impact of spinal cord injury and on the workability and how we can get back to work and all of that, just articulating the importance of work and why, most people just think, oh, you work to make money. But for other people, there are lots of different reasons for that. And so we're going to go into that a little bit more. And then also just identifying resources for returning to work. So just there are lots of avenues out there that can help people on that journey back to work. And I've explored a lot of them personally and some of them professionally as well. And so it's been really a good journey. They gave a quad a push button to push, so we're gonna make that happen. And hopefully these pictures are gonna play, so nope. everybody in my office knows that I'm the least technologically savvy person. So I don't know how to make that play. The mic. Okay, now we're back. So that was before me. So I just wanted to show that I did have a life before all of this injury. So I just want to share a little bit of my personal story. And some of you may have heard this before, so bear with me. But so previous to my injury, I was the bungee jumping, scuba diving, skydiving girl. So I was the girl who, in college, I went and studied abroad in Australia. I told my family, hey, by the way, I'm going to go study abroad in Australia. Mom said, okay, well, if you do all the paperwork, then you can go, thinking that there was no chance I was actually going to focus enough to get that done. But surprise to her, I did, and had so much fun. So I called him on Thanksgiving and told him I was going skydiving. And my uncle, I remember distinctly, he's like, Jen, you're supposed to call us when you're back on the ground. You don't tell us when you're going, you tell us when you come home. And so I missed that memo before, but here we are now. So, and I tell people all the time, I'm like, I was the bungee jumping, scuba diving, skydiving girl, but that's not what happened to me along the way. So after college, I went off to, I moved to Vegas, and I traveled 100% of the time. I was working in sales and had so much fun. I met so many people and learned so much about life along the way. And I did a lot of living from 20 to 25. And I tell this part of my story to show the independence, because I was super independent. And, I lived literally in a hotel for a year and a half all over the country. And so I was on my own. I had to meet people and go places completely on my own. And then I got a call for a drug rep position, and in true Jen fashion, I said, okay, I want to do that. So before I had the job, I just had a call for an interview. I called my current boss and quit my job, because that's what you should do, right? And it makes perfect sense. And decided, okay, I guess I'm moving home, moving to Arkansas. So came back to Arkansas and started that job. And so at 23, I bought the house and adopted the dog, and life was good. Made friends with all of my neighbors. And then one day my neighbor called me and said, hey, Jen, a bunch of us are going to the lake for the day. Do you want to come? And I said, well, sure. So all of my plans for the day had kind of fallen through. Had an open evening, so I decided to go. We went out on the lake, and there were a few of us that were out there that day. I rode with one person, the guy who had called me. And this was somebody I had never left my neighborhood with before, but we had been friends, and so I decided to go. So we got out there, and at the end of the night, we were on Lake Hamilton. I don't know how familiar you guys are with Hamilton, but we were there, and he wanted to show me all the houses on the water. So we were looking at all the different houses on the water. And while we were out there, we got out to where the water gets really cold. So if you guys are familiar with that, but we're out there, I'm sitting in the bass boat facing forward, and he was standing on the back platform facing backwards, and he lost his balance. And so he fell, and he sat on my head. And so if you think about that, he was, this high off the ground, and then falling 250 pounds on my spine. So initially, I had the whole bright white light, warm, pleasant feeling. And then right after that, it was a red hot searing pain. And I always think it's interesting, because I've heard so many other people talk about the colors of their injury. So I don't know what the science is behind that, but I think it's interesting just hearing people describe it with color. But so there was this red hot searing pain, and I knew immediately that I couldn't feel my legs. And so I told him, I said, you've got to get me help. You've got to call 911. I can't feel my legs. And his mantra for the rest of the night was, you're fine, you're being ridiculous. And so, again, I was a drug rep. I called on every hospital, every doctor in Hot Springs. So I knew a lot, and I knew that I needed help. And I knew that I was with someone who was telling me no. And so I begged him, you've got to call 911, you've got to get me help. And he just said, you're fine, you're being ridiculous. And so he drove me across the lake from as far out as we were. And I fell over on the side of the boat. I almost fell out of the boat that night. And I didn't think about upper body. I thought about just my legs. And so I didn't even comprehend that I didn't have trunk control. I didn't have control of my arms. I didn't have any of that. But we got, when he just stopped the boat and yanked me back to sitting. And again, I just begged him, call 911. He just said, you're fine, you're being ridiculous. And so we drove some more, and at that point I fell over onto him, and he just took my head and my shoulders and shoved me back to sitting. And I begged, just lay me flat in this boat. If you can't do anything else, just lay me flat in the boat. And he just said, you're fine, you're being ridiculous. And so we made it all the way across the water, and he loaded me in the boat onto the trailer. And so we got onto the trailer. So if you think about that, it's, this high on a boat trailer. And I just begged him. I said, you cannot get me out of this boat. Do not get me out of this boat. And he said again, you're fine, you're being ridiculous. So he picked me up, and I was just completely dead weight at that point. And he picked me up out of the boat, and he dropped me on the concrete. And so, again, I said, you've got to get me help. I was begging for my life. And he said, you're fine, you're being ridiculous. And he picked me up, and he carried me around to the other side of the boat, and he dropped me again. And at that point, I said, call 911, or leave me here. Someone else will find me. It was pitch black on a boat ramp. It was the middle of the night. And I said, somebody else will find me. You just leave me here. And he found some other man at the boat ramp, and the two of them, it was the back of the front seat and the console, and they put me face first, head down, into the truck. And I heard one of them say, well, what are we going to do with her legs? So they just picked my body up and put me in the floorboard of his truck, and he told me he was taking me home to put me in bed. And so, great neighbors. So anyway, again, I was just begging, you've got to take me to the hospital. And it was a 45-minute ride back to Benton. So we got almost home, and I started begging again. I was just like, you've got to get me help. And this is where it changed a little bit. He said, I can't take you to the hospital. I've been drinking, and I'll get in trouble. So I said to him then, I said, I'm not trying to get you in trouble. I'm trying to get me help. Pull your truck over, call my mom, call my parents. And he said, I'm not calling your parents. And I said, well, you've got to take me to the hospital, and what are you going to do with me? He's like, I'm just going to take you home and put you in bed. And so that was his plan. And at that point, I used words that I've never used in my life to tell him which hospital to take me to at that point, and that was what triggered with him that I was serious. So he took me to the hospital in Benton, and we got there, and there were some paramedics outside, and he got out there, and he told them, he said, I've got a girl faking it in my truck. So I've talked to the paramedic that first found me since then, and she's like, Jen, if I didn't need to take care of you, I would have killed him, because that's all she wanted to do at that point. But she saw me, and she said she could tell just from the way that my body was crumpled in the floorboard of the truck. She could feel the bones broken in my spine, and she said, we've got to get her help. And so everything started going right at that point for me, and that was the turning point for me. But she got a neck brace and a body board, and I was talking just like this. I was able to say, hey, this is my parents' phone number. My mom works here. Called them. My parents got that call in the middle of the night of, hey, we've got your daughter here on a backboard, and you need to come. And they had no idea what was going on. But they got out, and they came, and they were with me in the hospital the night while I was in the ER still. And I kept complaining because the backboard was hurting the back of my head. And I said, this hurts, loosen this a little bit. And the nurse came in, and he had a scan. It's one of the ones that you guys saw on the screen. And he said, Jen, your head hurts because it's what we thought. Your neck is broken. And that was how I heard it. And I'm like, what? I was thinking some nerve damage. I wasn't thinking broken neck at all. So it was quite a shock. And then at that point, they decided I needed to get transferred out. And so we needed a surgeon. And so I transferred out. They tried the halo. They did all the things. I think I had 70 pounds of pressure on my spine. And it was just jammed down and on itself. And so it was not going to release. And so we had to do surgery that night. And then the next night, my surgeon came by, and he squeezed my toe as he went by. And so y'all see that picture that was up there, that was my picture that I saw. We didn't even we couldn't even comprehend it at that point. But my surgeon came by and I said, I feel you, and he squeezed my toe, and he was shocked because we thought it was a complete injury, and found out that I wasn't, and in true PT fashion, it was a whole bunch of, well, can you feel this? Well, can you feel this? Well, close your eyes, and is it on the left side or the right side? And all the things that you guys like to torture us with. Thank you. So, but I was, very fortunate that I was able to feel and did have sensation and all of that. So anyway, I feel like some of you may have heard that story, and as Paul Harvey used to say, so here's the rest of the story. So from there, I went on to rehab, and I did extensive amounts of rehab. I did 2 months here in Little Rock. I was fortunate that you were still getting that amount of time at that point. This was in 2008. So I did 2 months rehab here, then went home for the scariest 5 weeks of my life, like that first initial going home where people are seeing you out in public and trying to navigate showers and getting in and out of bed and all the things. It's terrifying. So we did all of that, and then I got to go down to Shepherd Center in Atlanta. And I was there for about 8 weeks and learned tons and met tons of new friends, other people that were in the trenches with me, and just learning to walk and all the things. And then I came home and did outpatient rehab at that point, and then I got a call about a study that they were going to do down at Shepherd. It was going to be 6 months. And ironically, I did a whole bunch of therapy and ripped my neck out. So I got to a point that I had a wire coming through my skin. You could see it from inside that had worn a hole in the muscle, and so I'd have a revision on my neck on the same date of 2009 that I had it on 2008. So neck surgery, June 8th of 2008 and 2009, and my neck was still open when I went for the study. But luckily I got put in the control group and had to go back 6 months later and still got to go be there for 6 months of therapy. So at that point, I just knew that I was going to learn to walk, and I knew that I needed to be able to walk. That, for me, was when I would be whole. And so, but I saw everything that I was doing there, and I literally worked out until I passed out. I'm sure I was a dream from my therapist because I would say, woohoo, as I was passing out. And so they just knew, okay, we got to catch Jen. At one point, I even said to them, watch my face, as I was going down into a machine, and they appreciated that. But what that time frame did for me was it allowed me to see that I could either learn to walk or I could learn to live. And I got to see lots of other people that were years ahead of me that were still fighting for that. And for them, that's what they needed to do in their journey. But for me, I knew that I needed to let go of this learning to walk. And I'd gotten to the point that I could walk down and back on a basketball court, but it took 2 therapists and a walker and electrical stimulation and every ounce of energy that I could have possibly had. So it wasn't going to be sustainable for me. So I was able to let go of that and come home and learn to live. So I'd already learned to drive at that point. I'd gotten a vehicle converted. I'm going to talk a little bit about that when we get to the resources. But I came home and was able to build an accessible home. So we did tons of research on how to do that and was able to build it. This is my mom here, and I was able to build next door to them. So that way she was there, my parents are there and able to help me with anything that I needed. But I still had my own independence again, and that made a huge difference for me. But one of the things that I was given while I was in the hospital was a list of phone numbers. It was names and numbers of all these different organizations. And it was, okay, well, what do I do with that? So I saw Arkansas Rehab Services, and I literally called them and said, hey, I need an appointment. And I came in, I said, I have no idea what you guys do, but I'm here. So what do we do with this? And so they were able to talk to me through it and just told me, hey, if you're ready to go back to work or you're ready for independent living services, that kind of thing, then we can walk you through that process. And I said, okay, let's do that. So they actually were able to help convert a vehicle for me. So you guys saw in one of those pictures, it was a picture of my first Honda Element that I got converted. And so I learned to drive again, and that was so freeing for me. It was so much independence that I didn't have before. And because whenever I first got out of the hospital, I had one of the huge, full-size, accessible vans that all of my friends got to drive. So 25 with, it was not the minivan, it was the giant van. And it was kind of funny for a while watching all my friends drive me around in that. But I was finally able to drive on my own again and all of that. Well, so I became independent, got to the point where I could live independently, still with a little bit of help, but I got to that independence. And then I got bored. So I'm like, what am I doing? Like, I would find myself just wanting to have laundry to do and wanting to make dinner or something, you know, because those few meals out for lunch with friends weren't fulfilling me completely. And so it was time for me to figure out, okay, what's next? And so I decided, Mom mentioned something, she was like, well, why don't you take the LSAT? And I'm like, well, okay. And I was in a position that a lot of your patients will be, some of them aren't. It just depends on the situation for them. But where I had long-term disability. And so financially, I was okay. I was able to, you know, live comfortably with that from my drug rep salary. I was making 66% of my salary, and I could do that until I was 65. But that wasn't fulfilling to me. I needed something more than that. And so I started looking into my options. And so I decided to take the LSAT and was like, and that's the admissions test for law school. And I just said, okay, if this is supposed to happen, then it'll happen. So took the test and ended up getting a full ride to law school. And I said, okay, God, I guess this is what you have in store for me now. And so just opened that door, decided to go back to law school. I was working with the students. I see Twala here, if any of you have been her student at UCA. So I got to go be one of the guinea pigs for the students there, which was so much fun for me. And just for fun, I have to tell you all a fun story. One day, I'm always running late, but if I was going to drive to Conway, then I felt like I should also get to go to my favorite store. So I went to TJ Maxx. And I go flying into therapy as soon as I got there. And Twala's like, Jen, what do you have in your chair? And I'm like, what? What? And I looked down, and there was a bra on a hanger stuck in my chair. And I just looked up at her and I said, I stole it. And she's like, what? And I said, I stole it. And she's like, okay, so, you know, I've had some fun along the way. Apparently I turned into a thief at some point. And it was even more fun when I took it back to them. And I said, hey, I kind of stole this, sorry. And the manager was really strange with me. I don't know what that problem was, but anyway. So yeah, I'm the girl who stole the bra from TJ and took it to therapy with me, unbeknownst to me. So yes. Anyway, so now let's get on to why is work important? I don't get to see my pictures anymore, if I can figure this out. Maybe not. I don't know. Oh, okay. Perfect. All right, so this is just some stats, and you guys may not be able to see them, but the important part is just looking at the employment gap of people who have disabilities and are not working or are unemployed versus people who do not have disabilities. And so up in the top right, that's the gap that you're seeing there. And then in the middle on the bottom, you're seeing the poverty gap, and that is the people with disabilities versus those without disabilities. And so you can see that those correlate with each other really well. And so there's, pretty good incentive there for going back to work on the financial side of things. So, but as I mentioned, it's not just about financial reasons. So there is certainly financial, there's community reasons to get back to work, and then health reasons, just makes you healthier if you have a reason to get up and go every morning and gives you purpose, and then also independence. So anyway, for me, I had to go back to law school to do that. So I just decided that my career as a drug rep was not going to be sustainable, and being able to get in and out of so many offices and doing all of those things. And so I decided to go to law school. A couple of the pictures that you saw were me with a bunch of firemen, and there's a reason for that. My 1L meet and greet was in a venue downtown. So I went to meet all of my new classmates, and I called ahead to make sure it was accessible. They told me, yes, there's an elevator. Just take it down. I'll meet you outside. There's a key in the elevator. Leave it in the elevator so that it'll be here at the end of the night. At the end of the night, I went to go get back in that elevator, and someone stole the key, apparently, and it was not me. So no one in my class left until I could leave. And so they ultimately, after an hour or so of looking for a key, the fire department got called, and so they got to lift me and my 400-pound chair up the really small stairway to get me out. So all of my classmates knew my name by the end of that night. And then 3 weeks into law school, the power went out on the third row, or on the third floor of the school. So the same firefighters came and hauled me out too. So, you know, I bring the party whenever I come. So it was a good time. But the administrators in the law school, they were like, because all my classmates came to me, and they're like, Jen, what do we do? How are we getting you out? Like, we're not leaving until you get out, and we'll carry you out. And the administrator's like, no, this is what happens when you work with a bunch of attorneys. They don't let you do stuff like let your classmates haul your 400-pound chair down the stairs. So, yes. Anyway, so we did that. And then also in law school, I decided that I wanted to be a mom more than I wanted to breathe. And so I told my family, and Mom said, could you graduate law school first, please? And I was like, no, I can't. I'm ready. And I looked into surrogacy and adoption and fostering and all the things. I just felt like doors were closing faster than they were opening. And so in my 2L year, at some point, my doctor said, well, Jen, you can carry a baby. And I said, okay, enough said, let's do that. So single, quadriplegic Jen in the middle of law school decided to do some internet searching and find a donor. So my internet searches were kind of odd for a little while, but apparently you can buy whatever you need online. So we made that happen and actually ended up pregnant on the second try. And so the pictures that you saw were my son, and I got the opportunity to actually carry him. And it was just incredible. It was a great experience. And that was when I went back to UCA and did some more therapy and worked on, figuring out how to transfer with a belly and how to safely carry a car seat and how to get it in and out of my car and live independently with a baby at this point too. So we did all of that, and then, but that gave me more motivation whenever I took one semester off to figure out how to be a mom. But then I knew that I needed to graduate for my son. I needed to prove to him that Mama's got this and we can do this. And so it gave me even more driving force to do that. So we did that, and then I ultimately went back to work when I graduated at Arkansas Children's doing the medical legal partnership there. And so I got to help take care of a lot of kids that were any kinds of legal issues that they had. So whether it was education or domestic or all kinds of stuff, all full gamut of stuff. But I got to be there with my coworkers and experience that community that comes along with that. It was really, really cool. And they just accepted me. The first day that I went to work, my chair decided to quit in an elevator. So I got to teach my brand new coworkers how to put this thing in drive and push 400 pounds out of the elevator and down the hall. So life is a journey, and you just have to live it. So just to go ahead and mention a little bit more about my journey, I finished my fellowship that was there. It was 2 years, and then I went over to Disability Rights, which is where I am now. And during COVID, I got the opportunity to move to working from home, which has been fantastic. So now I get to work from my patio every day, which is awesome. That was my accommodation to be able to do that. At one point, I got a call. My mom's an OB nurse, and she called me and she said, baby for adoption. What do you think? And I said, yes. Okay, let's do that. So the pictures that you saw with a second baby, that is my baby boy, Roman. And so he was my surprise baby. I found out on a Tuesday that he existed, and on Friday, I was at the hospital when he was born and got to bring him home on Saturday. And so now I've got 2 baby boys that are my reason for getting up and going. But anyway, so let's get back to the work side of things. So you're going to have patients that are maybe newly injured, or they've been injured for a long time. They are either looking to get back to work for the first time, or they're trying to keep their employment, any of that. So just so you're ready to work, now what? Now what do we do? So with that, so there are some questions that you can kind of ask yourself on that. And it's, can I perform the essential functions of a job? And that's with or without reasonable accommodations. So you can, a lot of times people think, oh, well, I can't do that job as it is. But then you got to look at the accommodations and see if it's something that can be sustainable for you. And then one of those questions is, what are essential functions? And what is considered to be a reasonable accommodation? So essential job functions, those are the key reasons that the job exists. So it's really what the job is there to do. So the questions that you can ask for that is whether the position exists specifically to perform these functions, and the number of other employees who are available to perform those same job duties, and then the expertise or skills required to perform these essential functions. So that'll kind of give you an idea if it's something that's required of that job. A lot of times it's in the job description, and that's something that we look at whenever I'm talking to clients a lot. So, and then reasonable accommodations. So reasonable accommodations, it's just any change or adjustment to the job or the work environment that will allow the applicant or the employee to participate in the job. So it allows them to perform those essential functions. So I always like to mention some of the things that reasonable accommodations include, and then the things that they don't include. So it can include things like just providing or modifying equipment or devices, making your workplace readily accessible. For me, whenever I went to Children's, there was not an accessible bathroom on the floor that I worked on. And so they, made that happen for me. And they had an elevated desk for me so that way I could elevate my legs under my desk, so to prevent swelling during the day, that kind of thing. And so the first one was a pretty major accommodation, but the second one was pretty minor on what I needed. And I needed some dictation software so that my writing is not great, and it's very slow. So now with dictation software, I was able to, keep up with those demands. I wanted to be able to record phone conversations because I couldn't take notes the same way that everybody else could, and so it just made it a lot easier for that. So, and a lot of times, accommodations cost very little money, and it's just some changes that are happening within the workplace. And so, because you'll hear employers, they'll get a little nervous whenever they hear, oh, well, I'm going to need these accommodations. And it doesn't necessarily require a whole lot. A lot of them are free, and it's just moving to a different office or, light differences. I mean, there's all kinds of different accommodations that are there. So the things that reasonable accommodations do not include, so it doesn't need to be removing the essential functions of the job. And you don't have to lower production standards for these people to be able to do their job. It's not about providing personal items. So my employer is not going to be providing a wheelchair for me or a walker or glasses or any of those sorts of things. Those are still going to be required by the actual employee. And the other thing is it can't cause an undue hardship. And so if it's something that's just crazy expensive for a really small company, it's not going to be a requirement there. Okay, so going into the interactive process. So this is where you're asking for those accommodations. And someone can ask for accommodations either when they are applying for the job, because a lot of times you need accommodations just to make the interview process accessible for you. Other times it's once you have the job. And that's the thing too, it's always a question on when to disclose your disability. With me, if I'm doing a face-to-face interview, obviously you can tell from the beginning, and so it's an obvious disability, but a lot of times people don't have obvious disabilities, and so they have to decide at what point they want to disclose, because the employer is not allowed to discriminate based on disability. So that you have to make a request, and this request does not have to be, okay, hi, my name is Jen, and I have a disability, and I need a reasonable accommodation. You don't have to use any keywords with that, so employers really have to be listening to hear what the request is, and to take note that, oh, this is, an ADA accommodation or a accommodation for disability. So at that point, you have to provide information too. So depending on what the disability is, about how obvious it is. So this is where a lot of you guys will come in. So you may have a patient come to you and say, hey, my employer is requiring that I provide documentation for what my disability is and what my limitations are. And so you can really be helping somebody with that whenever you provide that information. And then you get to start looking at exploring accommodations. So I always recommend for people, you know yourself best, and so you come to your employer with the things that you think would work. But it's going to be an interactive process whenever you're talking about that. And so ultimately, the employer gets to make that final decision on what they're going to provide for you for the accommodation. But it has to be something that's going to work. And so you'll choose that accommodation, and then you'll implement the accommodation, and then also just maintaining, just to make sure that it's still working. And you can go back and forth, up and down that process as often as necessary. So what happens if you're not provided appropriate accommodation? So that's where you can look, first of all, to an internal resolution process. So that may be just talking to your manager, talking to HR, something like that. A lot of times those can be resolved at the lowest level, and that would be best case scenario. And if you're still just getting tons of resistance, you can look at the EEOC process. And that is just going in and filing a complaint. And so then you'll have to go through that process, and you may end up talking to me along the way. So now let's get into some resources. And I want to weave my story back into these as we go here too. So Arkansas Spinal Cord Commission. So these were the first people that showed up for me. Whenever my injury happened, we had no idea anything about spinal cord. I knew no one else that had a spinal cord injury at the time, but they were there in my hospital room within just a couple of days of my injury happening, and they showed us that we weren't the first ones that this had happened to, and there's a whole community around us, and that they were going to guide us and walk us through the steps. And it meant more than you can imagine to us that there was somebody there to be able to show us that this was going to be okay, and that they were going to show us the way. But they can provide case managers to you. For me personally, they actually went to the house with my mom, and they went to my house and to my parents' house just to decide which was going to be most accessible for me whenever I got ready to come home. Because again, those 5 weeks, that first day going home, let's see, the ramp didn't work for me, and we flipped a Hoyer with me in it. So all in the first day. So it's not an easy process. So just having somebody that's there and can help with those situations was invaluable for us. And so just remember that Spinal Cord Commission is there, and they are willing and want to help, and they can help all along the way. There is a conference coming up. The Arkansas Spinal Cord Conference is coming up, I think, in October, and they do that every couple years too, and it has been really invaluable as well. What I say, I learn more from the other people that are there than I do just from the speakers, because I'm actually talking to people who are living that life day in and day out. And so I've learned so many tips and tricks along the way for how to help with that. Okay. Then we have Arkansas Rehab Services. So this is the group that I told you guys whenever I had their list of numbers, I went and sat in their office. They actually helped with the conversion of my vehicle. They can help with things like helping to fund part of schooling whenever you're getting ready to go back to school. They can help with accommodations that are needed at school, at work, whatever. They can help with finding a job. All of those sorts of things, on-the-job training, supported employment, all of that. So they are a really valuable resource. I recommend for people to just reach out to them and just see, what they can offer in different settings with different disabilities. Division of Services for the Blind is kind of a sister organization to Arkansas Rehab Services. They do a lot of the same things. My work wife is blind, and so she's gone through Division of Services for the Blind, and she's used a lot of their services the same way that I've used Arkansas Rehab Services. And so just kind of the same idea there, but more of a specialized program for them. Okay, so the Work Incentives Planning and Assistance Program, that's the WIPA. So one of the things that I hear people say all the time is, oh, I can't go back to work because I'll lose my benefits. And that's a fair thing to think, and it is kind of something scary because you're thinking, I'm getting SSI or I'm getting SSDI or Medicaid or I have attendant care and all of these different resources that people are not able to let go of. And it's understandable that they're not, because those are big, valuable things, and they're afraid that, well, what if I don't make it? What if I try work and I can't do that? For me, I mentioned to you guys that I had a long-term disability plan. And so I knew that the day I went back to work, I lost that. And that was something that was going to cover me till I was 65, or I went back to work for one day. And so I needed to really make the decision. So that was why I chose school over going back to work first, or one of the reasons that I chose that. But the WIPA is fantastic about being able to talk people through that process and being able to explain to them how the Social Security benefits work and all of that. If you call me and ask me, I will just direct you straight to WIPA because there are a lot of intricacies that go along with that, but they've got a great hold on it and are able to really direct people. There's also, and I don't have it on this slide, I wish I did, but Workers with Disabilities Medicaid as well. So it allows people to keep a Medicaid program even if they're working in the state of Arkansas, and it really is a big benefit because that's where a lot of the attendant care comes in for people. Okay, so going back to that slide that we looked at earlier about poverty for people with disabilities, a lot of times people are not able to ever bridge that gap and get out of that, and part of it is because they only allow you to save $2,000 and all of that, and if you have more than that in your account, then you lose benefits, that kind of thing. Well, the Arkansas Achieving a Better Life Experience, otherwise known as an ABLE account, is something that can really benefit people. Currently, it is only for people whose injury happened before the age of 26, or I should say their disability happened before the age of 26, but in 2026, that number is actually raising to 46. So that will be a big change that's coming. And it really helps so people are able to save money that they're going to use towards their disability and living the life that they need to live. And that is really important because living with disability is really expensive. Job Accommodation Network. So this is something that we use regularly. If we've got somebody who's saying, well, what do I need to do about accommodations, and what are my rights as an employee, and what are my rights as an employer, whichever direction that goes, you can go to askjan.org, and they are fantastic at being able to go through. You can list different disease states, different injuries, all that sort of thing, and it'll actually pull up a whole list of accommodations that are available for different things. And so things that you might not have ever thought about are available out there. There are tons of webinars, there are tons of different training programs, all of that. So I highly recommend checking them out if you've got somebody who's looking to go back to work. Okay, and then Increasing Capabilities Access Network, otherwise known as ICANN. So this is another organization that I absolutely love. I think they've got a booth outside too. But it's great for if you're wondering, I wonder if that technology would work for me. I wonder if this would be something that would benefit me. And it's basically a library of assistive technology. And so you're able to go in and touch and feel and try different things. They have an online website so that you can go and look and just explore there. Or if you're in Little Rock, you can go to the building and check it out and see. They also do resources where if you want to donate used equipment, you can there, and then they are able to give it out free of charge to people. So I've actually gone and dug through their closets a little bit along the way just to see, what's available out there. And one of the things that I've borrowed from them have been ramps whenever I've gone on vacation and needed different ramps for different settings, and access tracks when I go to the beach and want to get out in the sand. It's just like building me a red carpet out on the sand, and so it works really well. So I do recommend doing that if you've got somebody who's just trying to figure out, will this work for me and will it not? Okay, so we're at the end. Any questions that anybody has? Yep.
One thing, it's an amazing story.
Thank you.
Gosh, what was I going to ask? Outside of the physical recovery, cognitively, was there a process you had to go through, or did you have any cognitive injuries with your?
I didn't with mine. So for me, it was just the spine. You have to get through a lot of the mental, emotional side of everything. I had to rebuild confidence, all of that. For me, having a huge support system, I say all the time, I couldn't make it without my village. And I needed to get to that point. And it took years, honestly, for me to feel confident enough to really be out and about and going back. And going back to work was a big deal. I wondered if I could make it, and I just had to try it and prove to myself that I could. And I feel like that's the way it is for a lot of people.
Well, obviously you didn't quit.
I didn't.
That's great.
I don't know what that word means, I don't think.
No,
so, yes.
Well, thank you.
Thank you.
Thank you so much for your story. Your story is amazing.
Thank you.
I am a former special education teacher, but I'm
Okay.
also a disabled combat veteran. So I've
awesome.
overcome a minor injury in comparison to yours. But my question is, some people sit and dwell on where they are in life, what's happened to them. And some people are able to just drive through like you did. What do you think the difference is, and what helped you be able to do that?
I don't know the answer to that completely. I know for me personally, a lot of it had to do with my faith, and I just knew that I was going to be okay every day. I was going to be okay, and but there were hard days. There were really, really hard days along the way, and I just needed other people around me to pick me up and say, we're going to keep going. We're going to do this. And my mom's here today. She's been my biggest supporter the entire time. And I really think that meeting other people with injuries helped. I think that seeing them and knowing that we were pushing each other to move forward was a huge benefit for sure. So, and I should mention there are VA services as well for veterans as well. I didn't have that in this presentation, but that is certainly an avenue. So explore it too. So.
And I have one other question.
Sure.
What happened to the gentleman that did this?
I have no idea.
So he never faced any consequences?
No. So we called the police the night of the injury, and they just said, sounds like an accident, first of all. And I don't think we had the person making the call, I don't think he had the full understanding of everything that had happened at that point. Later, it was passed over to the Game and Fish people. They came to my hospital room. I did an affidavit. They told me that the charges would be kidnapping and first-degree assault because he took me against my will, and they never followed up on it. For me, though, personally at the time, that wasn't my focus. And I just said, he's got 2 kids. I don't need him locked up. I need me to get better. And I firmly believed at that point that I was going to be completely fine. Everybody that said, the chances of you walking are very slim, I was said, hide and watch. And, that was my plan. I just planned to be completely whole at that point. So that couldn't be my focus. I needed to focus just on my recovery. I wish him well. So, yes. So, anybody else? Sure. I think that you can give a realistic view of maybe some stats and what you've seen from other people, but I'd never want you to tell them that they can't. So, I needed to know that I had some hope and that I could push as hard. I will tell you, as myself and from what I've heard from other spinal cord injury patients, is I hear all the time, oh, well, so-and-so had a really bad injury, but they just tried really hard. They worked really hard in therapy, and now they're completely better. Oh, I'm like, really? Okay, well, good for them, and I am very happy that they made a full recovery, but I don't think they worked harder than me. I think their injury was just different than mine. And so I have to be very careful whenever I say that. But I just want to say, don't ever completely squash their hope, but do give realistic expectations. And connect them with other people too. Anytime you can connect them with other people, I think, that are in the same situation. And if they need to be connected to somebody, I've got cards. You can connect them to me too. I'm happy to talk to anybody. So, yep.
How was the process of converting your car, and are there like certain cars that you can or can't convert, and how did you pay for that? What resources were there? I know you mentioned the one, but how did that process go?
Okay, so it is a lengthy process and it is very expensive, I will tell you that. So the typical cars that you see are like minivans. So that's kind of what you see typically in Arkansas. For me, I was 25 and wasn't feeling a minivan at the time. So, and ironically, as a drug rep, I drove a minivan, which is really funny to me. But I didn't want that in this life. And so I had to go out of state. So I went to Michigan to Freedom Motors to get that vehicle converted. I had to buy the Honda Element, and it's the same deal. I bought a Tahoe, is what I have now. Y'all may have seen those pictures. My kids call it the robotic car because it's got the gull wing door on it, so I get lots of looks, and people stop me all the time and ask me about it, which is kind of cool. But I had to go to Indiana for that one. I had to pay out of pocket for the vehicle, just did full financing like anybody else would for a vehicle. But then I went through ARS, and they were able to, so Arkansas Rehab Services, and they were able to pay for the conversion side of it for me. So that was a huge help because those conversions are $25,000 to $40,000. So it's not cheap. And if you've got somebody who's not working and not in that position yet, and even if they are working, that's an expensive vehicle for anybody. So it's, it's hard. So, yep. Oh, I'm glad you said that. So I went through OT for that, and there was a man that used to work at Baptist, and more power to any of you therapists that are doing drive training, because he got in the car with us, and I told him then, I said, hey, I don't want to check a box and say that I can drive. I want you to teach me to drive because I've got a car that I'm going to get, and I'm going to be doing this. So I need to be safe when I do this. And I will tell you, it took me a year to have the strength to be able to get there. And so it did take a while. And there are all kinds of conversions. I've got clients right now that have just a little joystick, essentially, that they're driving from. And so don't mark it off if you can't do. I use hand controls with a tri-pin to steer and then hand controls to drive with. But I had to learn that process. But there are huge amounts of technology out there to allow people with all different capabilities.
Was there a program that helped pay for that service to get trained? Like, I heard that there's a program here in town, I'm not from here, that they can go to classes for so many, like 33 weeks or something, a long time, to get learning to drive. I have a friend that her daughter came drove here to do that, but I live 2.5 hours away, and so I was just curious, and then too, like, was there a ARS or somebody that helped pay for the
That is who I would call to start with on that. I don't know that answer. I know that I did it through rehab, so my insurance was covering it when I was doing it, but I think there are some external sources for that, and I'm just not familiar with them. But ARS is a good place to reach out to. Anybody else? All right. Well, thank you guys so much. Oh, I'll take this back from you.
Let me, yeah, I'll grab that real quick. Thank you. Great job.
Wait a second to get off the stage.
So if you have any more questions, you can contact Jen there. Great presentation. All right. Okay. Thank you, Jen. Do you want me? I'll go ahead and, yeah, go ahead. Got it? Great. Stand by. Okay. All right. So at first they told me to not to hold everybody away from lunch, and I'm like, I don't know who wants to get in front of that charge, but we do. Just as a reminder, there's the QR code for your evaluations. We just want to put them out there so that you've got it right then and there. So the way we're going to, the lunch plan is if you go out that door right there, and I think you have to go back to your right, and you'll see lunch right there. So, and of course the exhibitors are open. We will start at 1 o'clock promptly. So now this is your 54 minutes off. So, all right. Thank you.